we were treating acute myeloid leukemia with 7 and 3. Today, in 2019, we're still doing the same. So
Right.
going forward, how can we imagine changing this by 2029?
So it's not an easy question to answer. As I've learned a little bit more about the complexity of these diseases, and thinking about information that's coming out of solid tumors as well, I think we're all paying much more attention to the concept that these diseases are really diseases of the entire tissue and not just the hematopoietic cells. So I worry that when we choose therapy, we're basing it on the properties of the hematopoietic cells as we understand them. And we're not really appreciating the environment in which the cells reside. We're not appreciating the crosstalk between the stroma and the hematopoietic cells and how each of them can remodel the other. And so we're not really treating the environment. We're treating only the hematopoietic cells. And I don't know all of the answers, but I have begun to believe that we really have to think about multiple treatments and really using treatments that alter the diseased microenvironment as well as the diseased hematopoietic cells.
Thank you. That's refreshing to hear that you want to go beyond the obsession with genomics that everyone else seems to have. My second question is, there's 3.5 million papers on cancer.
Yeah.
135,000 in 2017 alone. There's a staggering disconnect between important biologic insights and our ability to convert those into improved therapies for our patients. What are we doing wrong?
Well, in part, I would answer that question in the same way that I just answered the previous question. I think I'm always surprised by every year there's a new finding, and we're beginning to peel the next layer off the onion. I don't think that we have really defined all of the cellular processes that have gone awry. So I apologize, I'm getting back to the idea of genomics. But I think that we don't yet have an integrated picture of really what's happening completely in these tumor cells. We're beginning to understand DNA-based changes. We're beginning to understand some of the epigenetic-based changes. But we haven't really, we're just learning that RNA epigenetic modifications can affect normal cell growth and cancer cell growth, and that epigenetic patterns in RNA are altered in tumor cells. We're beginning to see changes in protein and protein modifications, and we haven't put all of that together into a comprehensive picture. So we're only basing our treatments on that tip of the iceberg that we see right now. So I think that part of what we need to do is to keep working to develop a more comprehensive picture. I think some of the computational approaches that we have now are going to make it easier to integrate all of the different detailed information that we get in to understand the interactions between cellular pathways and how they're altering cell growth. So that's a long and short way of saying that translational research is hard. We all know it's hard. We don't have enough people doing it. We don't have enough research support. We often have a deficiency in access to human samples to study this, and that's where your own work and your own resources have become so important to understanding MDS. But even when we do have all of those things in place, we don't yet have a full picture of what's happening physiologically.
Thank you so much. Very sobering to realize that. I mean, so just thinking about all the complex issues that have to be studied, then it's going to be a very long time before we see this kind of translation happening. But then I have another concern. The fact that children respond to the same therapy for the same disease better than adults means that the host is different or the biology of the disease is different. Now, the problem is that cancer is a disease of the aging. So having perfect therapy to target the cancer cell may not be enough because the host is so decrepit. Your solution?
Yes. No, I agree with you. I'm not sure I have a solution. I think that you said it perfectly. I think that both the host and the disease are different. I think that just speaking about myeloid leukemias in the elderly, I think it's skewed towards very high-risk, aggressive diseases. And I think the disease in children is different. I think, we see, genetically we see difference in the disease, in myeloid diseases in children, and than we do in the adults. And I think it's a combination of, again, the host is different, the leukemia cells are different, the microenvironment is different. We've spent the morning, Dr. Raza and Dr. Costini, having a great conversation about changes that occur as we age in the bone marrow microenvironment, and I think that that is again affecting how hematopoietic cells function in elderly people, and I think that the disease in children is that AML in children is shifted more towards translocation type AML, whereas in the elderly it's shifted more towards deletions of chromosome 5 and loss of chromosome 7 and deregulation of dysfunctional bone marrow microenvironment. And now you have a disease of the whole tissue, and we're not yet really treating the whole tissue. So I think it's both. And so that it doesn't provide a very satisfactory answer, but I just think we have to tackle the disease differently. We have to look at it differently and study it differently.
No, I think you're absolutely right, and this is why I feel very concerned that even when we have a perfect model, the same disease in a human, but they are just younger, we can't use them as a model. Then
Right.
how are we using mouse models and animal models to study human diseases
Right.
when you can't
Yeah.
use a younger model of the same species? Anyway.
True.
Now,
Yeah.
Michelle, you are very unusual, where very few people have your caliber of exposure to the highest leadership in cancer research in this country, which means in the world. So you are not only aware of the resources
Yeah.
that are available, and I don't just mean the monetary resources, I mean the intellectual resources in the country, because you sit on leadership committees who review a lot of what's going on nationally. So and you have great experience in the field. You are cancer center director at a major university in the country, so you are one of our top 1% people in this, and we are very proud of you. But that means
Yeah.
the question to you will be tougher. Now, with all this knowledge, if we give you limitless resources to cure cancer, what do you think should the solution be?
So I think that one of the areas that we have not yet paid enough attention to is prevention. And that's obviously not going to help us cure AML in the elderly. But I think that one of the things that I'm intrigued by is that we are now beginning to have the technology to integrate what are the risk factors in the 21st century for cancer, and to be able to integrate information on genetics and individuals' genetic makeup at many different levels, at the RNA level, at the DNA level, an individual's lifestyle risk factors, their medical history, their infection, their toxic exposure, their environmental risk factors. So things like understanding stress, poverty, noise pollution, all of those things to integrate, to understand what is our risk factor. And I think and on top of that, then we have to layer on genetic differences based on our race and ethnicity. And I think that the time is right now to be able to develop this very integrated picture. So in a way, I'm far more interested in prevention, early detection, and some of the new technology for ablating early lesions like breast, prostate, even pancreatic lesions now, as kind of a long-term solution to really reduce the incidence of cancer in the nation. That being said, I think boy, I'm not sure how to answer that question. I think that we don't yet have good ways to model tumors in 3 dimensions in organotypic cultures. I think we're beginning to understand that. I think our models are partially recapitulate the human situation, but not completely. So I think we need to develop better models. I think we need to develop better screening approaches. I think we need to be able to monitor tumor cells as we treat them, to really be able to predict what tumor cells are going to respond quickly to chemotherapy, and be able to kind of stay one step ahead of the tumor cell by seeing it in vitro or in single cell assays, kind of how tumor cells are adapting to different treatments and how they're developing resistance mechanisms. So I think all of those things need to come together to develop a better treatment approach. At the same time, we'll come back to the idea of a complex tumor environment. We really have to begin to better integrate the whole 3-dimensional picture of tumors, including all of the immune cells, and really understand how those cells are interacting before and after treatment. I've been very interested in some of the approaches applying Darwinian approaches and evolutionary biology approaches to understanding how tumors evolve genetically. But I don't think that those approaches are really truly integrating the possibility of kind of the bottleneck effect and what happens with clonal selection, and when you force a cell to evolve in a complex tissue environment. So I think all of those things are things that we need to learn about if we're really going to be able to predict how a tumor cell is going to respond to therapy. So those are some of the approaches I would take if I had unlimited resources, and unfortunately that would require developing a great number of collaborations that I don't have at the moment with people with very diverse expertise.
But I like your systems biology basically approach, that you can't have a reductionist
Right.
attitude.
I don't. I think we're getting beyond that. I think we've almost learned as much as we can from the reductionist approach.
That's the key message I'm getting from you, which I think all of us agree with completely with you. Thank you so much. Last question is a bit philosophical, and it's important for you because you are directing a cancer center. And the question I have is that offering patients who have advanced but incurable cancers treatments that are not going to even prolong their lives beyond a few weeks or months, but will cause tremendous pain and toxicity, and many of them will become bankrupt and lose all their life savings. Is that advisable in the current landscape? Is it a service or a disservice in your opinion?
Well, I would say it is almost a personal decision. You are in a very challenging position being a physician and having to make that decision about what you offer to patients. It's easier for me to sit back and just philosophize about this. I think there are times when palliative care is necessary, for example, to reduce pain inpatients and using radiotherapy in some instances to reduce pain. In other instances, I do question whether or not an individual patient would want to undergo therapy if they could predict what some of the pain and consequences, what some of the financial toxicity might be. But at the end of the day, to me, it's an individual decision. For myself, I probably would not choose to undergo extensive treatment and end-of-life care, but other people might.
Thank you so much. That was a beautiful answer, actually.
Yeah.
Thank you for your time.
Oh, well,
Pleasure.
well, the pleasure is mine. Thank you, Azra.